Okay guys, let's go for the today's class involving a classic 10 marker chronic regional pain syndrome. Let's break down. So it involves chronic, also called complex regional pain syndrome. So complex means it has variable presentations. Regional, it involves a particular region or a limb and not the nerve distribution. The pain will be disproportionate to the injury, and it is a syndrome which involves that is a cluster of signs and symptoms. So let's go for the types. The types of CRPS. So type 1 will be it has no nerve injury. So it was previously referred to as reflex sympathetic dystrophy or Sudak dystrophy. Type 2 is also called causalgia, which involves a partial or complete nerve injury. So if the type which doesn't come under type 1 or type 2, it's referred to as CRPS non otherwise specified. That is, the criteria are met but symptoms do not meet. So what are the stages? Stages have been given by Lansford and Evans. The stages involve acute, it's from 0 to 3 months. It involves warmth, redness and burning pain. Subacute involves 3 to 12 months, also called dystrophic stage, as worsening pain and dry skin. The chronic or atrophic stage involves contractures and fibrosis with loss of hair and decrease in pain. So the acute stage, the most important investigation of choice or the identifying key point will be three-phase bone scan will be positive. In subacute stage, there is subchondral osteopenia. In chronic cases, extreme osteopenia. So now we have seen what is the breakdown of the chronic regional pain syndrome, also called CRPS. Then we have seen what are the types, that is type 1, type 2 and non otherwise specified, and we have 10 stages as acute, subacute and chronic. Now we will go for pathophysiology. So whenever there is an injury, what happens, there is activation of cutaneous nociceptors, which in turn leads to retrograde depolarization, which at the site from the sensory terminals, there is a release of substance P and bradykinin, which in turn causes the symptoms. So there is something called autonomic dysfunction, that is, there is temperature and color change occurs at the site, and there is something called CNS neuroplasticity, that is, there is pain amplification. So what are the cardinal signs here? There is increased severe pain, swelling, stiffness and skin discoloration. So other features will be vasomotor disruption, that is tropic changes, that is hair loss, and there is hyperhidrosis, that is increased sweating, which can be found using a sweat test. And there is something called flamingo gait when the knee is involved, and involuntary movements, and equinovarus deformity if ankle is involved. This is not important that much. So now what should be your diagnosing criteria? So there are, since it's haphazard, the presentation is very complex, so there has been a criteria at Budapest. So Budapest criteria involving continuous pain for a longer time and at least one symptom, that is of 3 to 4 categories. Sensory, that is allodynia, increased sensation, vasomotor or asymptomatic temperature on both the limbs, pseudomotor, that is swelling and sweat changes, motor or tropic changes, that is decreased orem and weakness, and at least one sign for each of the above criteria, that is sensory, vasomotor, pseudomotor and motor. And the fourth criteria will be no other explanation for this particular pain. So what will be the investigation of choice? So first investigation, always whenever the CRPS is involved, first to take an X-ray to see for any patchy osteopenia, and to check, main investigation choice will be 3-phase bone scan. So it has 3 phases. So the first phase, we involve by injecting a tracer, technetium 99 mm, into the vein. It's a painless procedure. So phase 1 is done immediately using gamma camera to detect hyperemia, that is blood flow. So the phase 1 is called flow phase. Phase 2 is done 2 to 5 minutes later, which is to identify soft tissue and to check for the blood pooling. So it's used in diagnosis of cellulitis, synovitis and septic arthritis. And after a break time of 2 to 4 hours, the third phase is done after 2 to 4 hours, which is delayed phase, which is targeting the skeletal area or targeted area to see for fractures, occult, infection, metastasis and periprosthetic pathology. So this you can keep a note on it. It's a repeated MCQ. So in phase 1, 2 and 3, in case of osteomyelitis, in all uptake will be increased on all 3 stages. In cellulitis, only on first 2 stages. In stress fractures, mostly on third, because third involves the bone. Prosthetic loosening, also the third uptake. Periprosthetic infection, since it's an infection. So now we are gonna see other investigations. The third one will be thermography, that to differentiate between the temperature between the limbs, right and left. Then nerve conduction study, electromyography for CRPS type 2. So type 2 is what? Type 2 is also called causalgia, which is a partial or complete nerve injury. So here the investigation of choice will be a nerve conduction study. So again we have seen bone scan has flow phase, immediate, blood flow phase which comes around 2 to 5 minutes, and the delayed phase which comes 2 to 4 hours. So how to prevent CRPS? So whenever there is a patient with fracture, you give them a dosage of 500 mg of vitamin C for 50 days to prevent CRPS type 1. So again, type 1 revision, it's a no nerve injury, reflex sympathetic dystrophy and pseudocaustic dystrophy. Then what we can do is we can opt for physiotherapy. So what physiotherapy you want to do is like mirror therapy and early mobilization. So medications will be to give analgesics and neuropathic agent. And nerve stimulations like TENS, peripheral nerve stimulation and spinal cord stimulations can be done. The final stage will be to give nerve blockade with agents like lidocaine or sympatholytics, and the chemicals most commonly used are phenol and alcohol. So sympatholytics, that is chemical sympathectomy, is done at stellate ganglion for upper limb and lumbar spinal ganglion for lower limb. And peripheral nerve blockade and epidural blockade can be done. And finally, if there is no option and the patient has severe pain, you can go for surgical sympathectomy, that is excision of the ganglions or electrocautery to elevate